Wouldn't it be great if there was a cream that could get rid of post-sclerotherapy pigmentation? But after reviewing the evidence, it's clear that topical agents won't get rid of all post-sclerotherapy pigmentation completely. It's also clear that we need to think about ways to reduce the severity of PSP in the first place. And let's be clear, if you look carefully enough, you'll find post-sclerotherapy pigmentation after every treatment session. In fact, post-sclerotherapy pigmentation is an expectation rather than a complication or side effect. It's a sign of successful treatment. In most cases, post-sclerotherapy pigmentation is self-limiting and pigmentation will disperse completely after about 6 months. But we do have mitigation strategies to reduce its severity and clinical impact. And there are things we can do if post-sclerotherapy pigmentation persists beyond 6 months or if it continues to get worse. And that's what we're going to cover in this video. I'm going to cover why the published evidence figures vary so widely, the 2 patterns pigmentation can take, the risk factors worth knowing, and 6 practical prevention strategies and the full staged approach to managing post-sclerotherapy pigmentation if it persists beyond 6 months or continues to deteriorate. This is part 2 of a 2-part series based on the peer-reviewed review Richard Oliver and I have written for the Journal of Sclerotherapy. Let's get started. In the literature, you will see very different numbers quoted for how common post-sclerotherapy pigmentation is. And that variation isn't just random, it comes down almost entirely to one thing: the concentration of sclerosant used. The commonly cited range of 10 to 30% of patients affected by short-term post-sclerotherapy pigmentation comes from Goldman's landmark 1995 paper. But a systematic review by Bossart and colleagues broke that down by concentration, and the numbers are striking. Polydocanol at 0.25%, the incidence is 2 to 12%. With polydocanol at 0.5%, it rises to 12.5 to nearly 68%, and with polydocanol 1%, it rises from 13 to over 73%. That is the difference between under 3% and nearly 3 in 4 patients, and it's almost entirely explained by sclerosant concentration, which is the single most controllable variable you have as a practitioner. And here's another thing: foam sclerotherapy consistently produces higher rates of post-sclerotherapy pigmentation than liquid at the same concentration. So that's important too. The reassuring part is the natural history. Goldman and colleagues reported that 80% of patients with pigmentation clear spontaneously within 6 to 24 months. Roughly 70% resolve by 6 months, and persistent pigmentation beyond 12 months affects a small minority, 1 to 2% in clinical practice. So it's not a huge problem. There are 2 clinical patterns, and recognizing which pattern you are looking at tells you something important about the cause. Linear staining follows the exact course of the treated vessel. It presents as a dark brown line where the spider vein used to be, and it's caused by the breakdown of intraluminal thrombus, releasing hemosiderin along the vessel lumen. This is the most common pattern, and it's also the most easily mitigated against, because early evacuation of that coagulum at the 2-week mark significantly reduces the incidence of post-sclerotherapy pigmentation. Diffuse staining is different. It's broader, cloud-like or coin-shaped, and it doesn't follow the vessel course. It comes from vessel wall disruption, typically because too much sclerosant was injected at a site, it was pushed in with too much pressure, or the sclerosant concentration was too strong. This pattern is usually more extensive, more distressing for patients and more likely to persist. If you see diffuse staining, it's almost always telling you something about the technique or the concentration. And if you follow my low, slow, low, low hold technique, this should mitigate against this problem. I cover this in another video, and I'll put a link to that in the description below. There are established risk factors. On the patient side, darker Fitzpatrick skin types, 3 to 6, carry more risk because melanocytes are more reactive to inflammatory stimuli. Elevated ferritin has demonstrated a linear relationship with pigmentation risk in prospective studies, although a later analysis found that relationship was not always consistent. So treat it as a contributing factor rather than a reliable predictor on its own. Estrogen is worth a specific mention because the laboratory evidence is more complex than people often assume. In vitro work on human melanocytes found that estradiol increased melanocyte proliferation, but actually decreased melanin content and tyrosinase activity. So the relationship between estrogen exposure and pigmentation risk is not simply a straightforward stimulatory one. Estrogen exposure is also thought to increase capillary fragility, which is a separate mechanism. So the quality of the skin also affects pigmentation. Hemosiderin deposits in the reticular dermis show through thinner overlying skin, and sensitive or reactive skin with an amplified histamine response also increases local inflammation and endothelial cell contraction, which allows more red cell extravasation. On the procedure side, concentration is again the standout factor, with incidence rising from under 12% at polydocanol 0.25% up to 73% at 1% polydocanol. Foam is more potent than liquid at equivalent concentration. Perivascular extravasation from poor needle placement, excessive pressure, or injecting with too much force lets red cells leak outside the vessel. A large intraluminal coagulum leaves more substrate for hemosiderin formation. This is debatable. I'm not sure this is a great contributor, but it's thought that inadequate compression lets blood re-enter the sclerosed lumen, and UV exposure in the peri-treatment period stimulates melanocytes in already inflamed skin. So the current wisdom is to apply compression hosiery and avoid sun exposure, but it's hotly debated amongst experts. What I would say is that if you've got large reticular veins, eccentric compression with a stocking over the top might reduce post-sclerotherapy pigmentation. So let's look at our 6 prevention or mitigating strategy. Strategy 1, use the lowest effective concentration of liquid sclerosant. For telangiectasias, that means 0.25% polydocanol. And reticular veins, that means 0.5% polydocanol liquid. If you want to use STS, I would suggest 0.1% for telangiectasia and 0.2% for the reticular veins. If you're using foam for C1 disease, and a lot of my colleagues now are switching to foam, particularly with the new Verixio devices, reduce the concentrations further to account for the increased potency of foam versus liquid. Strategy 2, treat reticular feeder veins before the spider vein clusters they supply. This reduces intraluminal filling pressure and it limits the tendency for blood to re-enter the treated vessels. Strategy number 3, evacuate the coagulum early. At the 2-week review, look for areas that are bulging, tender, or starting to darken. A simple nick with a 19 to 21 gauge needle and gentle compression of the retained blood dramatically reduces hemosiderin formation. A study that I've quoted showed that microthrombectomy significantly reduced pigmentation rates for veins of 1 millimeter or smaller. Strategy 4. Consider adequate graduated compression. Kern and colleagues demonstrated in a randomized control study that compression significantly reduced pigmentation after sclerotherapy. Another study showed that an additional 3 weeks of class 1 compression, 20 to 30 millimeters of mercury beyond the immediate post-sclerotherapy period, further reduced pigmentation rates. Strategy 5. Advise strict avoidance of exposure of the treated areas for 2 to 4 weeks and use a broad spectrum SPF 30 to 50 or higher when outdoors. It's a low cost, low risk strategy that very often is left out of aftercare instructions, and many think it's very important. Personally, I'm not so sure. Strategy 6. Consider pharmacological adjuncts in higher risk patients. And here I want to be absolutely clear, because 2 agents come up in this context and they don't sit on the same evidence level. Sulodexide has been tested in a randomized controlled trial. Of 720 enrolled patients, 609 completed the 3-month follow-up, and oral Sulodexide was taken for 1 week before and 3 months after sclerotherapy, and it reduced pigmentation incidence from 14.8% to 8.7% at 1 month. This is a proper randomized trial, and Sulodexide is licensed in some countries in Europe, the Middle East and South America, but it's not widely available, including not in the UK. Micronized purified flavonoid fraction, MPFF, was studied in a large national observational program involving over 1,100 patients, and it was associated with a reduction in pigmentation rates from 41.2% to 33.9%. That's a really useful signal, but it's an observational study, not a randomized trial, and the two should not be considered in the same light. They don't carry the same weight of evidence. For established pigmentation, treatment follows a staged timeline based on how long it has been present. In the first 6 weeks, for all cases, reassurance, strict sun protection, graduated compression, and coagulum release at the 2-week review if needed. From 6 weeks to 6 months, if pigmentation persists, continue sun protection and compression, and consider adding a topical depigmenting agent. I covered the evidence for those agents in detail last week, so I won't repeat it, but here's the table, and I'll put a link in the description so you can see the evidence and watch the video for yourself. From 6 to 12 months for persistent pigmentation, the triple combination cream should be considered. You should also consider Deferoxamine mesylate, subcutaneous or intradermal, used off-label. And again, both of those are covered in full in last week's video and article. Beyond 12 months for resistant pigmentation, this is where energy-based devices come in. Q-switched ND YAG laser with or without IPL. It causes selective photoacoustic fragmentation of both hemosiderin and melanin granules, which macrophages then clear via the lymphatics. Most of the evidence for this comes from small case series rather than randomized trials, so it should be treated and read with that in mind. Now, if you found this video useful, please consider giving it a like and sharing it with your colleagues so we can get the word out. And make sure you subscribe. That way you won't miss my next video. My name is Dr. Haroun Gajraj of the Vein Care Academy. Thank you for watching.